Hi everybody, this is Dr. Burghardt. I'm going to make a video now on your Pharmacogenetics and Psychiatry worksheet. We're basically going to go over it, and then if you guys have any more questions, you can shoot me an email. So let's start with the case. Lindsay C. is a 5'5", 125-pound, 34-year-old African-American female who presents to her primary care physician with complaints of obsessive-compulsive disorder, uncontrolled by medications or individualized psychotherapy. She has a 10-year history of this disorder and has been on multiple medications with inadequate relief. Her obsessions revolve around near constant thoughts of her daughter dying. She finds relief from these thoughts through a ritual where she repeats her daughter's name 5 times. This is distressing and it interferes with her ability to work as she is distracted and her compulsions use a substantial amount of her energy and concentration. She feels hopelessness because she's tried so many different medications and nothing seemed to work. An evaluation by the pharmacist of her medication history and recommendations on pharmacotherapy is requested. So your first task here wasn't even pharmacogenetic based, I suppose. It was to identify pertinent objective and subjective information needed from the patient's chart and history. So you had some starters here. She's a non-smoker. She has no alcohol, drug abuse, and she has no known drug allergies. So what are some other ones from the case that you could probably put in subjective information? Some of them could say she has obsessions with her daughter dying. And along with that, her compulsion to kind of quell the anxiety from that obsession is to repeat her daughter's name 5 times. Some other possibilities is that her current OCD is uncontrolled and interferes with her work. And finally, right now she's feeling hopeless because nothing's working for her. In terms of objective information, you were given that she's on Paroxetine 40 milligrams daily with currently no response. She's also tried fluoxetine, venlafaxine, duloxetine, fluvoxamine. Each failed due to no response. So she has quite a long and significant history of medication non-response for her OCD. Some other information that's objective in this case would be her 10-year history of OCD. What else do we have? She's 5'5", 125 pounds. If you want to, you could calculate a BMI. I can just you can eyeball it and tell that she's not really obese. But it's probably useful to calculate that as well. She's 34 years old. She's African American, which is important in terms of our case we're going to talk about today. And then, we need to look at her labs, which come up next. And what we see here is quite a long panel of labs. And really, she's essentially normal in almost everything. She's pretty borderline, I would say, on her potassium. Highlight that. Everything else, including her CBC, her renal function, her liver function tests, are normal. So then we get to the pharmacogenetic side of her labs. And what you see here is they have the columns pharmacogenetic, diplotype, genotype, HLA, and phenotype. So we got to figure out what these mean, right? So from your class, you do know that CYPs are those metabolizing enzymes. So these are genetic variants related to those CYP enzymes. And we have a couple phenotypes here that you'd have to go figure out if you didn't understand them. And what basically they're telling you here is NM is a normal metabolizer. So theoretically, we're not too concerned with anything that's a normal metabolizer on this list. So she's a normal metabolizer for 2C9, 1A2, 2C19, 3A4, 3A5, and 2B6. However, we probably should highlight this one. For 2D6, she's an ultra-rapid metabolizer, and that's actually shown here in the genotype because she has a duplication at this gene. And when you have a duplication at CYP2D6, you tend to have increased activity, increased transcription of the gene, and therefore your enzyme tends to be in overdrive. What other genotypes we have here? We have COMT, that one, and again, what you should have been doing during this activity, once I give you the resources in the next area, and you're trying to figure out your gene-drug pair, is trying to figure out which ones are important for this case. So let's see, we have COMT, and that's a gene that is relevant to psychiatry, but it's more involved in the folate cycle. She's normal. She's homozygous for HTR2A, which again is a serotonin receptor subtype, if you guys don't remember that. 2C, looks like she's heterozygous for that, so that one could be a possibility given that she has OCD. MTHFR, again, is a folate metabolizing gene. She's normal. HLA-B is the gene we worry about with mood stabilizers and some neurologic medications in Stevens-Johnson syndrome. She's negative for that. OPRM1 is a gene that's sometimes looked in pain. It's the opioid receptor gene. It's normal for that. SLCO1B1. This is a big one for statins. Normal there. And VCORC1. It just says warfarin. So you'd have to go figure out if this was per se a cardiovascular case, then you'd probably have to go figure out what that means. However, again, since we're talking about psychiatry, what we're going to end up coming back to is any genes that are maybe associated with psychiatric side effects, or drugs in general, I should say. So this brings us to our first question. What subjective or objective information in the patient history, not the genotype results, but something else, could be important for developing and assessing a pharmacogenetic profile? So when you want to look into a patient's history, especially when you're also trying to do a pharmacogenetic consult, one of the biggest things, and this is even without pharmacogenetics in psychiatry, and you guys probably remember, is previous medication trials and family history of drug response. So, for example, previous medication trials, we'd be trying to look for some sort of pattern that's occurring in this patient's previous medication trials that tell us something about side effects or efficacy that you could start to pin on a single pathway. So you're looking for patterns of non-response or side effects. Because if you start to understand that if this person was put on all medications that were 2C19 and they experienced significant side effects, maybe this person has an issue with 2C19. Maybe if they're on all serotonergic medications and they had non-response there, maybe they have some sort of serotonin genotype dysfunction as well. So additionally, family history of drug response, right? This basically gets down to the fact that we get half our genetic makeup from mom and from dad. So if you have some sort of family history of drug response, this can be a potential predictor of genetic variation involved in drug response. So that's why we're looking at that family history of drug response, especially in these disease states, psychiatric disease states that have very large genetic components. One final one that we want to think about when we're doing a pharmacogenetic consult is race and ethnicity. So as we'll find out in a few steps, this can lead us to certain genetic variants, their rates of occurrence or prevalence can differ depending on race. So in the end, what we're really trying to do is pick out certain aspects of a patient case that will help lead us to basically target certain genes that'll help us make recommendations. So that really looks at that first question. So let's move on to task 2. Given the information presented above, identify and formulate a pharmacogenetic-based assessment of this case. In order to do this, I kind of ran you through steps. So using your previous knowledge and available medical and pharmacogenetic resources, identify the primary drug class utilized for the patient's disease state, and identify pharmacogenetic targets that are backed by level 1 evidence. So you must list your references or resources used in your answers. So to help you do that, I gave you a very short article on drug information databases. So let's open that up. So this was that first link, Pharmacogenetic Resources, PharmGKB and the Clinical Pharmacogenetics Implementation Consortium. So after doing a quick review of what the heck pharmacogenetics actually is, it gets right into the nuts and bolts here. So for the Pharmacogenetics Knowledge Base, or PharmGKB, is the premier repository for pharmacogenetic information. PharmGKB's website encompasses a multitude of resources, including genotype-based drug dosing guidelines, drug labels with biomarker information, pharmacokinetics and pharmacodynamics, drug-centered pathways, and summaries of important pharmacogenetic associations. This is basically an NIH resource that was started in 2000, and it's constantly curated by scientists with essentially pharmacogenetic backgrounds. And so these are basically PhD supported scientists that go through the literature and constantly update PharmGKB. So this is really why PharmGKB is the premier website or database for use when looking up pharmacogenetic information. So if you remember anything, pharmacogenetics knowledge base. And additionally, it goes through all the several things that it has, but PharmGKB also provides access to publish pharmacogenetic guidelines from multiple groups worldwide, including the Dutch Pharmacogenomic Work Group. So they provide their own guidelines, DPWG for short, and then the Clinical Pharmacogenetics Implementation Consortium, or CPIC. And interestingly enough, because most level 1 evidence, which we'll see in a second, is based on guidelines, PharmGKB actually provides these kind of interactive pages where you can use CPIC guidelines and input your own variants, and it'll tell you basically what to do based on those guidelines. So piggybacking off that, the second website that's really useful is the Clinical Pharmacogenetics Implementation Consortium itself. So CPIC for short. There it is. And essentially it's a partnership between PharmGKB and the Pharmacogenomics Research Network. And basically its purpose is to address barriers for pharmacogenetic implementation. So what happens is that once more and more information and data is published for given gene-drug pairs, they get put on a list to basically create guidelines by a group of experts. So each guideline focuses on a drug or drug class and one or more genes with variation of known impact phenotype. CPIC guidelines themselves are a standardized format and written according to standardized operating process that has been published. For example, tables 1 and 2 in the guidelines always summarize the prescribing and dosing recommendations. So no matter what gene-drug pair it is, when you go pull down that publicly available CPIC guideline, it'll always have the recommendations in Table 1 and Table 2 because that's how they write them. So, in summary, these are your two go-to resources. If you're in the pharmacogenomics elective, we'll go through it more in detail. PharmGKB and CPIC, the Clinical Pharmacogenetics Implementation Consortium. So we just looked at articles on pharmacodrug information databases. Now let's use this level grading system because I asked you to only pick a gene-drug pair that's backed by level 1 evidence. So let's go see what that means real quick. So the link I gave you here was to PharmGKB itself, and it really explains their clinical annotation levels of evidence that those PhD scientists assign to every single data piece that comes through PharmGKB. And as you can see, level 1A and 1B are high evidence, and essentially that has a CPIC guideline, or perhaps a known clinical implementation, but usually that's captured in a CPIC guideline. As you go down, the evidence becomes quote-unquote worse. However, level 2, 2A is still pretty good evidence. It means that the variant's actually a PharmGKB very important variant, and then you get down to level 3 and 4, which are really either the gene and drug haven't been studied very much, or it was, for example, a retrospective study, so the evidence is low quality. And if you were to go down through each of the levels here, you would see them, and you could read through them yourself. But what we're concerned with, again, is that level 1 evidence, which really is that CPIC, or Medical Associated Society endorsed pharmacogenetic guideline. Now that we have these two kind of breadcrumbs, I guess you could call them, hints under our belt, let's think about answering this question. So step 1, again, using your previous knowledge, what we need to do is identify the primary drug utilized for this patient's disease state and identify the pharmacogenetic targets that's backed by level 1 evidence. So what's the patient's disease state here? And the patient's disease state is OCD. So your job was to basically go find papers or guidelines that basically tell you what is the primary drug class utilized in OCD. And I think you guys are quite good at this now. You can go to different softwares and different databases and different library resources and clearinghouses to find those guidelines for OCD. So I'm going to go through just a few of the resources I found to direct me towards the drug class that is the primary drug class in OCD. So I found these through PubMed searches, through Google Scholar searches, and through generic internet searches as well. So this first one here is from the Anxiety and Depression Association of America. And they give you the full breakdown of OCD. They give you some pathophysiology and some background on it. Then it gets right into the treatment options for practice guidelines for OCD. As you can see, they give you some first-line treatments for psychotherapy, and then they go right into pharmacotherapy. And right here, FDA-approved SSRIs for OCD. So there's actually SSRIs approved for OCD, and they give them here: fluoxetine, paroxetine, and sertraline. And then the guidelines actually do improve, or at least include, some SSRIs that are not necessarily FDA approved, but still appropriate for OCD. And basically you continue for 8 to 12 weeks, including 4 to 6 weeks at a maximally tolerated dose, be considered an adequate trial. Some others that I found were from the American Family Physician, and so this was a paper by them, Obsessive Compulsive Disorder Disease and Management by Fensky and colleagues from the University of Michigan. This one's fairly recent as well, 2015, getting a little bit older, but the evidence hasn't changed substantially. And they have some key recommendations for practice, as you can see here. They go over the epidemiology, the course of illness, etc., that you would expect in a guideline. And as we go down, they go through the DSM-5 criteria for actually diagnosing OCD. Then we get way down here to treatment, and they give you a whole treatment tree that starts with assessing the severity of OCD and then going down through here. And then you can see they tell you mild to moderate. You should either go option A or option B or both, which is CBT or an SSRI with or without CBT. Or if it's a severe case, it needs to go directly to an SSRI with or without CBT. So essentially, again, SSRIs are the primary drug class that's utilized. They give you the starting and the target doses, and they even put some costs in here, which is kind of nice. So that's another example of a guideline that I found. And then finally, this last one's an article from JAMA, and this one's much more recent, 2017, Obsessive Compulsive Disorder Advances in Diagnosis and Treatment by Hirschritt and colleagues. It looks like they're from the Department of Psychiatry from the University of California at San Francisco, UCSF. So again, they go through what would be, essentially, they did a full systematic review looking at all the different trials that have looked at OCD and including other agents as well. And what they found here, based on their evidence review, is that selective serotonin reuptake inhibitors compose the first-line pharmacologic treatment for OCD given their documented efficacy in reducing OCD symptoms and demonstrated tolerability across multiple trials. Meta-analyses of blinded placebo-controlled head-to-head trials have failed to demonstrate meaningful differences in efficacy between SSRIs, however, which suggests that despite the labeling differences, all SSRIs can probably be treated as equally efficacious for treating OCD. So, moral of the story here is that in 3 different resources that I found that I would have just put in for this work, you didn't have to necessarily put things in AMA citation format. You could have just put the link in there. I found 3 different resources that all point to SSRIs as being the target drug class. So my drug, I haven't found my gene yet, but my drug for the drug-gene pair is the class of SSRIs. Okay, so identify the primary drug class utilized for a patient's disease state and identify some pharmacogenetic target or targets that are backed by level 1 evidence. So given that I told you what databases to go to, let's go ahead and go to them and see what pops up. So if we go to PharmGKB and we actually just type in selective serotonin reuptake inhibitors, it'll bring you to an overview page on this class of medications, very handy here. And if you click on clinical annotations, because that's where the level evidence will be, what you'll find is that level 1 evidence appears to exist for CYP2D6 in paroxetine, CYP2C19 in sertraline, CYP2D6 in fluvoxamine, and CYP2C19 citalopram, escitalopram. So, very interesting. You can scroll over and you can see the phenotypes that they have on it. And if this is level 1 evidence, right, let's click on it. And what it will take us to is the actual level 1 evidence. You can see here that it gives you different phenotypes based on the patient's CYP2D6 genotype. So, thus far, we're thinking that CYP2D6 is likely a high candidate for our gene, as well as CYP2C19. However, just for our own sake of completeness, let's go ahead and go to that CPIC website that I linked you to as well. So here is the CPIC website, cpicpgx.org. And you can see here, it gives you an overview of what CPIC is, which we already went over. And up here, you can look for a few different things. You can look at the publications, the alleles they've actually reported on, gene-drug pairs, and guidelines. So I always start with the guidelines because that's going to be the most robust evidence. It's already been curated, it's already been evaluated, and it's so good that the experts have developed guidelines on them. So let's click on guidelines, and then you can either search for selective serotonin reuptake inhibitors or scroll down the page, and what you'll actually find here is they have a CPIC guideline on CYP2D6 and 2C19 and selective serotonin reuptake inhibitors, and again, if we go back, what you can see here is that the drugs included here are all those from PharmGKB that had level 1A evidence. If you actually click on the CPIC guideline, what it will take you to is the publication itself and any updates that it has. So it always shows you what tables are in the guidelines, it shows you the supplements, etc., etc. And it's always very useful to have this because you can just actually click on the paper, which is always open access, and you can go right to the CPIC guideline, which have essentially all the information you need for this assignment, but also just in general, all the information you would need on that drug gene pair. So again, our genes are CYP2D6 and 2C19. That's supported by level 1A evidence in PharmGKB and a CPIC guideline, which go hand in hand. Remember, level 1A evidence means that there's some sort of guideline that backs it. So we found 2 genes, right? You might ask yourself, Dr. B, how do you know which gene's better? Should we do both? The answer is you could do either, or you could look at the patient-specific outcomes, or at least information, data that we have in this case. So let's go look at it again. Remember, we highlighted it. CYP2D6, they're an ultra-rapid metabolizer, so that seems like a pretty good gene to test for here, or at least to include in our recommendation, versus CYP2C19 is a normal metabolizer. So in the end, we're probably really not too concerned about CYP2C19. And really, CYP2D6 is probably what we're going to base our recommendations on. Because again, they're just a normal metabolizer for 2C19, so really there'll be no pharmacogenetic recommendation to be had here. Okay, so for the task, we are on task 2. Give the information presented above, identify and formulate a pharmacogenetic-based assessment of this case. We're at step 2. So for your identified gene-drug pair, so in our case it's SSRIs and CYP2D6, list an overview of the gene that includes possible genotypes, alleles, diplotypes, and phenotypes. You only need to list 2 genotype examples for each phenotype if that phenotype has multiple genotypes associated with it. So where do you go find this information, right? Go back to the resources I gave you before. So the easiest area for me to find this information is in a CPIC guideline. So right here, the CPIC guideline for CYP2D6 and 2C19 SSRIs. So if we scroll down and go to that first table where all that good information is, you'll see this is the assignment of likely phenotypes based on diplotypes. So exactly what I'm asking you for in the table. So since we're, again, only really interested in 2D6 in this patient case because they're a normal metabolizer for 2C19, let's put in that info for 2D6 into the table. So you can see there's 4 different phenotypes: ultra-rapid, extensive, intermediate, and poor metabolizers. And this is basically true for all CYPs, except for the only caveat is not all CYPs have an ultra-rapid metabolizer phenotype. The 2 that do are actually in this guideline, CYP2D6 and 2C19. So let's put those in here. So for extensive or normal metabolizer, these are used interchangeably. You can, if you're a normal metabolizer, sometimes they just call it an extensive metabolizer. They're interchangeable. And also often, rapid or ultra-rapid metabolizer are generally put in the same group. This can actually depend on the given CYP, but for our cases here, they're a rapid or ultra-rapid metabolizer. So let's go back and get those genotypes, or diplotypes that actually go with each phenotype. So for ultra-rapid metabolizer, you can see what's here are duplications of the gene. So again, we talked about this earlier. This is what this patient actually has. They have a duplication of the functional alleles, leading to increased activity of CYP2D6. So let's put that in here. I'm lazy, so I copy and pasted, which if you did that, fantastic. But again, my point here is you only needed to list 2 genotype examples for a given phenotype. So if you just put in one of these 2, 1 times n, 2 times n, something of that nature, I'll be happy with it. Then we have extensive metabolizers. And what is an extensive metabolizer? That's that normal metabolizer. And it's usually coined for most CYPs by star 1. But CYP2D6 is highly heterogeneous. It's highly polymorphic. So there's actually several star alleles that we might not think would be an extensive metabolizer that actually lands you in that extensive metabolizer group. There you go. So again, the standard one we usually think about with most CYPs is star 1. But again, CYP2D6 is a little bit special. And for intermediate metabolizer, you can see here they have some combination of what would be considered a poor functioning allele, but not so poor that it's what would be considered non-functioning. So that would be intermediate. And finally, let's go grab those poor metabolizer diplotypes or genotypes. And you can see here poor metabolizers. And there you go. So they are made up of some sort of form of non-functional alleles. And again, CYP2D6 is very polymorphic. So there's several of them here. And there we go. So we have the table filled out now. Again, these are not the only answers that are here. If you use different resources, and given how polymorphic CYP2D6 is, you could have many different types of alleles in here. I just wanted you to really understand the connection between a genotype and the phenotype. So let me just say a few other things about this table real quick. These tables are real nice because they'll tell you approximately how many patients land in these different groups. So as you can see, the majority of patients are normal metabolizers, and then anywhere from 5 to 10% are intermediate and poor, while a very low number, but not an insignificant number, are ultra-rapid metabolizers. This activity score is unique to CYP2D6. And essentially, it's something that's not really utilized quite often yet, but it was developed because of the polymorphic nature of CYP2D6 so that you could really pin down an actual activity score. Basically, the higher score you have, the more active the enzyme is. So people who are poor metabolizers have no activity. People who are ultra-rapid metabolizers have more than double the normal activity, where the normal activity would be 1. If we compare a highly polymorphic genotype like CYP2D6 to more standard CYP genotype that we would think of like 2C19, you can see some differences here. First off, there's a lot more patients that land in the ultra-rapid metabolizer group and in the intermediate metabolizer group, which means there's less patients in the normal metabolizer group and about the same number in the poor metabolizer group. And then, in contrast to the really complex diplotypes that we see with CYP2D6, 2C19 has really the standard diplotypes that we're used to seeing, especially in the normal, poor, and intermediate phenotypes, which is to say star 1 is normal, and then some combination of star 1 with a poor metabolizer phenotype would be considered intermediate. And then finally, you'd have to have 2 poor functioning alleles to be a poor metabolizer. And again, 2C19 is one of the 2 special CYP genotypes that have ultra-rapid metabolizers. And for 2C19, it's actually not a duplication, but an increased function allele, and that increased function allele is star 17. So if they at least carry 1 copy of star 17, they will have increased function of 2C19. So we're not talking about 2C19 in this case, but I just wanted to compare and contrast these 2 CYP genotypes. Okay, so on our journey to make a pharmacogenetic assessment of this patient, we're at step 3. So now taking into account our patient's demographics and characteristics, what is the expected frequency of each allele variant you defined above? So this is why I didn't want you to put 100 different genotypes in here, because it would be impossible to deal with. Instead, I really just wanted you to kind of look at the main genotypes, if that's what you ended up putting in your table, but at least look at some genotype frequencies. So you need to identify the frequency for one allele if the phenotype has multiple associated alleles. So let's see how I did that. So again, there's many different areas you could go to figure this out. I just stayed in the CPIC guidelines because the CPIC guidelines give you all that you need. See Supplemental Tables, S3 and S6 for information on the chances of observing specific diplotypes in different race or ethnic groups. Oh, okay. So these frequencies of race and ethnicity is not put in the main paper in CPIC guidelines. You have to go to those supplemental tables, which again, if we click on guidelines and then click on the guideline for SSRIs in CYP2D6 and 2C19, it brings you to everything you need. So let's go find those supplementary tables. So let's see. Association between alleles, okay, and frequencies of CYP2D6 in major race and ethnic groups. There you go. And it looks like they update this table over time. So let's click on it and see what it gives us. So what it will download for you is an Excel sheet, which I'm opening up now. Let's expand this up. And what this does nicely for you is it actually gives you exactly what you need. So what's the key feature for this patient that we need in order to put the correct frequencies on the table? And that's because we need to know this patient is an African American. So we're interested in this column right here. All right. So you can see I copy and pasted them in here. So let's just double check, what does this actually mean? So for an African American patient, for CYP2D6, what you'll find is that the chance of someone having a star 1 allele is about 20%, right? Because this is a frequency, so just multiply that by 100. For someone to have, an African American, to have a duplication of the star 1 allele, you can see that's pretty low. That's only 0.8% of the population. For someone to have a star 2 allele, it's about 15%, and so on and so forth. So something I think that's always good to notice when you go to the frequency table. So let's go back over the frequency table. is comparing them in different populations. And so let's just do a standard comparison between African Americans, Europeans, and East Asians. So for star 1, they're all pretty similar, right? In that 20-ish range. For star 1 times 2 duplication, they all have very low frequencies. And then we start to see some differences for star 2. You can see it's about 15% for African Americans. For European Americans, it's nearing 30%. And then East Asians tend to have a similar frequency, about 12%. So let's find those variants that are a little different from African Americans. So if we scroll down, we can see that the star 41 allele seems to be, again, less common in African American East Asians versus European descent. But interestingly, there's a higher frequency of star 5, which would be a poor functioning allele in African Americans, versus star 4, it's much less common and almost non-existent in East Asians versus Europeans. So again, this is why in pharmacogenetics, it's really pivotal to know the race and ethnic makeup of your patient when you're formulating pharmacogenetic assessments, when you're recommending pharmacogenetic testing, because if you don't do the right tests, if your panel doesn't include the right alleles even within CYP2D6, you might have really high false negative rates. Okay, so this is how I filled out the CYP2D6 frequency table. There are many other ways. You could have gone to specific papers, which I can certainly send links to if that's what you did. That's perfectly fine. I just find the CPIC method that you guys now know, if you weren't able to kind of figure that out, is really just easy and straightforward. They give you a straight up Excel sheet to use for it, and it's fairly easy to use. But there are other ways you can find it, including PharmGKB and through PubMed research articles. So let's look at step 4 in our assessment. So although population frequencies are quite useful for determining risk of carrying a given allele, what are some factors that might place patients, quote unquote, outside of the population frequency estimates? So for this question, I just wanted you to think about the differences between population averages and then individual patients. Population averages are great for making big decisions and guiding us towards decisions, but we always have to take those patient-specific factors into account. So what's something that you guys came up with? When I think about it, the main thing that comes up in my head is that not everybody fits into a cookie-cutter kind of definition of race and ethnicity. So one of the most common things that are going to push patients out of the population frequencies that we see in those tables are multi-ethnic, multi-race, diverse populations. And why is that? Because obviously these studies that are conducted to find these population frequencies, they either use very stringent questionnaires or potentially genetic analyses to place patients, or subjects we should say, because they're research studies, into specific race and ethnic groups to determine those population frequencies. But as we know, people are a lot more than generally one thing. They have very diverse backgrounds. That's why Ancestry.com is a thing. So this is one of the main things that'll place patients outside of those quote-unquote population frequencies that we see in those tables. Another thing that could place patients outside of the population frequencies might be age. It might be disease states. As you guys have learned, age has a big effect on your CYP enzymes metabolizing capabilities, so it can either mask genotypes, which we'll actually talk about later. And then diseases can definitely have effects on your body's ability to metabolize as well. So these are the things that might place patients outside of those frequency estimates that we kind of think about. But really the main one here that's going to really skew a genetic estimation of a genetic variant, I should say, estimation, is that multi-race, multi-ethnic, diverse population. Okay, so step 5 of the assessment plan is based on this patient's information. What is their genotype, phenotype status, and what is the theoretical effect that we think will have on the gene-drug pair? So essentially what we saw and what we talked about earlier is that this patient is an ultra-rapid metabolizer for CYP2D6. So theoretically, right, we would think that this patient will have lower drug levels of almost any CYP2D6 metabolized drug. For our specific patient, if we go back and look at the actual history here, what we see is that this patient has basically been on all CYP2D6 medications. So that might be a problem, because what would the theoretical effect be here? Again, that's lower drug levels. So it's very possible that even when putting this patient on the standardized doses recommended in guidelines, she never had the drug levels that she was supposed to achieve to have adequate control over OCD. And on top of that, OCD generally requires higher drug doses. So putting someone that's an ultra-rapid metabolizer on a CYP2D6 drug, where they'll just naturally have lower drug levels for a disease state that generally requires much higher drug doses, is really just a recipe for bad luck and failed trials. Okay, so we figured out our drug-gene pair. We figured out that this patient is an ultra-rapid metabolizer. She'll probably have lower medication levels and probably explains all her failed trials. So let's look at this question before we get to task 3. Complete the following table based on the predicted possible phenotypes for your drug and give the implication or effect, recommendation, and classification of recommendation for the patient's drug therapy of paroxetine. So let's go ahead and fill in those phenotypes that we've already done before. So what do I put in here for CYP2D6? Because that's what we're talking about here. Is ultra-rapid metabolizer, extensive or normal metabolizer, intermediate metabolizer, and a poor metabolizer. Now let's talk about the implications of each of them. First, for an ultra-rapid metabolizer, it would be increased metabolism. For extensive metabolizer, it would be just normal metabolism that we would generally expect for the majority of the population. For intermediate metabolizer, what we would expect? We'd expect reduced metabolism and therefore higher drug levels. And then for poor metabolizer, we really would expect greatly reduced metabolism or possibly no metabolism. And this would lead to much higher drug levels. So what do we think the therapeutic recommendation, if this patient landed in each of these given phenotypes, would be? Really, it would be select alternative therapy, if possible. This would probably be initiate as recommended. We'll say that. This one could be possibly one of two ways. So initiate as a recommended, or possibly decrease dose. Then what we would think for a poor metabolizer would probably be select alternative therapy or drastically reduce dose, right? And the classification of the recommendations, again, because we're working in a guideline, would all be 1A. So I know what you're thinking so far. Dr. B, how would you expect us to fill all these out just by kind of looking at it like you did? The answer is I wouldn't. So let's go to the guideline and actually see what it says. So if we go back to our trusty CPIC guideline for SSRIs, CYP2D6 and 2C19, let's get to the meat and bones here, which is the actual recommendations, which is always table 2 in the guideline. And you can see here, dosing recommendation based on paroxetine for CYP2D6 phenotype. Wow, that's exactly what I asked you to do in the homework. Kind of a coincidence, I suppose. And that they also have different dosing recommendations for fluvoxamine on a 2D6 genotype, and then they also do it for citalopram and S-citalopram for 2C19, and finally for sertraline and 2C19. So a bunch of different dosing guidelines in this one, but again, for our question there. We were just interested in the dosing recommendation for paroxetine. And let's look at it. Let's see. So they did it the same order I did it. Ultra rapid metabolizer, extensive, intermediate, poor. And essentially, we went over this. You get decreased plasma levels, normal metabolism, reduced metabolism leading to higher plasma levels, possibility of side effects. And then for poor metabolizers, you have greatly reduced. And this one, again, increases the possibility of side effects. What would be the therapeutic recommendations per CPIC? For ultra-rapid metabolizers of CYP2D6 on paroxetine, select that alternative drug not metabolized by CYP2D6. So for our patient, I think we probably could go with 2C19 drug. If they're normal metabolizer, continue as normal. And CPIC actually for an intermediate metabolizer just says initiate therapy with a recommended starting dose. So really probably what that recommendation comes from is studies not showing any effect or at least increased side effects for intermediate metabolizers on paroxetine. And as you can see, the evidence is not that good there. And then a poor metabolizer here. So select alternative drug not metabolized CYP2D6 or consider a 50% dose reduction. So we went over those, and as you can see here, the classification of recommendations actually differs based on the different genotypes, and that just differs on the studies that support it. So very strong evidence, likely 1A with both of these here. So you could put strong, if you put that in the table, that's perfectly fine too. If I was to be technically accurate in the table, I should put that this is moderate evidence. And this one, poor metabolizer for CYP2D6 and paroxetine CPIC, actually labels that as optional, meaning that the evidence really isn't very good there. So another way you could have done this is you could have gone back to PharmGKB and looked up those recommendations and levels of evidence directly in PharmGKB. So again, going back to our selective serotonin reuptake inhibitors search that I showed you before, clicking on clinical annotations, we see here paroxetine and CYP2D6. If you click read now, it takes you into essentially the area that shows you all the information that we needed to get before. So basically it shows you a phenotype here based on each of the genotypes. And what we see here is that the level of evidence actually assigned to paroxetine and CYP2D6 is actually 1A for all these alleles or haplotypes, they call them here, for paroxetine. So again, if you had put 1A in the table, fantastic as well. CPIC just gets a little more specific than PharmGKB because they're actually promoting a guideline based on what they think is the strongest evidence. Okay, and then task 3 as a pharmacist. So I guess I didn't explain in the beginning. These are really tasks that you should go through when you're doing any sort of recommendation for a patient, but specifically for a pharmacogenetic recommendation. So let's look at those tasks again, since I didn't do a very good job explaining this in the beginning. First, you need to basically go over the data you have for the patient, so the objective and subjective information. So it's kind of like a SOAP note. And then you do an assessment, right? Which we did. This patient, we found that we think that CYP2D6 and SSRIs was our dream drug pair. We found out that this patient is an ultra-rapid metabolizer for 2D6, so likely they should be avoiding any 2D6 medications in OCD because OCD really requires those higher doses. And then finally, we need to prepare that pharmacotherapeutic plan for this patient, starting with our goals of therapy. So what do you think some goals of therapy would be for this OCD patient? So one would be decrease symptom frequency and severity. A critical one for this patient would be improve patient functioning. She seems to be having a really hard time. And then along the same lines, improving her quality of life so that she can get back to not having such severe obsessions and compulsions. For our long-term goal for almost any pharmacotherapeutic plan you make, you always want to achieve lifelong remission in psychiatry. So let's transition to our drug plan. What should be our drug plan here? Well, the patient's currently on paroxetine, right? So we probably want to DC that, right? Because due to them being an ultra-rapid metabolizer, they'll have way too low levels. So, and this is also not even just supported by the fact that she's an ultra-rapid metabolizer, but the fact that all of her previous trials that have mostly been CYP2D6 medications have been failures. So in that place, you could have several different recommendations. Because I teased that CPIC guideline previously, and this person's a normal metabolizer of 2C19, I went ahead and said, let's start citalopram. And if you went to the guidelines, it would say probably initiate about 20 and increase to 40 with possible further increases, depending on the guideline that you're looking at. Let's go look at CPIC real quick and make sure that we have the right pharmacogenetic recommendation. Okay, so I got you in CPIC. We're on table 3, which is dosing recommendations for 2C19 and SSRIs, specifically for citalopram and escitalopram and 2C19. This patient is an extensive metabolizer. They have normal metabolism. So initiate their therapy with a recommended starting dose, which we're going to do, and they consider that strong evidence. So we seem to be right on the track. It seems to be like a pretty good plan. So really our rationale here is, and I won't write this down, but we're just discontinuing. We're following CPIC's recommendation to discontinue paroxetine due to the ultra-rapid metabolizing CYP2D6 and go with a therapy that's not metabolized by CYP2D6. This patient's a normal metabolizer for 2C19, and that's the main pathway of citalopram's clearance, so we're probably in the clear here. However, we might have to use higher doses than even what we're starting or achieving with 40 here, because OCD generally requires higher doses, and escitalopram and citalopram has some reasonably strong evidence in OCD, and even that one guideline I showed you from JAMA, there is no strong evidence suggesting one SSRI over another, so really that just means patient-specific factors come into play, which is what we're doing here. So now we've arrived at this question. Suppose this patient was on an omeprazole for GERD. How would this change the recommendation to use citalopram? What is phenoconversion? So first you need to ask, well, why is Dr. B asking about omeprazole, and what does that have to do with citalopram? So I think most people, you probably remember, even without looking at micromedics, is that there is some sort of drug-drug interaction here that's occurring. So the drug-drug interaction that's occurring is an interaction between omeprazole and citalopram, occurring via what? That's right, 2C19, because omeprazole is actually an inhibitor of 2C19. And if we went ahead and went to an actual drug-drug information resource, we can figure out what that drug-drug interaction is. So let's go do that. As you can see here, I enter in citalopram and omeprazole into Micromedics' drug-drug interaction program. What we can see pops up again is a major interaction, which is what we expected, where the concurrent use of citalopram and omeprazole results in increased citalopram exposure and a supposed risk of QT interval prolongation. So again, how does that actually occur? You can click on here. Inhibition of 2C19 mediated citalopram metabolism by omeprazole. Okay, so what we found was that it increases citalopram concentration by inhibiting 2C19. So the other question is, what is phenoconversion? Phenoconversion is a phenomenon that converts genotypic extensive metabolizers into phenotypic poor metabolizers. And it doesn't necessarily have to just be extensive or into poor metabolizers. The basic point of phenoconversion is changing your genetically determined metabolizer phenotype into a different metabolizing phenotype by a drug-drug interaction. So often what people will call this is a drug-gene interaction. So it causes this person to act like a poor CYP2C19 poor metabolizer, which in this case might actually be somewhat useful because we're looking for slightly higher levels of citalopram in an OCD patient. But again, we need to be aware of this because it might actually lead to side effects that are obviously undesirable in our monitoring for this patient. What would our plan be here? It would probably be to monitor and consider dose reduction of side effects or risk of side effects is present. So again, phenoconversion is just a fancy word for a drug-drug gene interaction. So what some other ones you could have? You could be, for example, a CYP2D6 poor metabolizer, and you could be put on a CYP2D6 inducing drug, and that would lead you to have a phenoconversion where you almost act like a extensive metabolizer. So again, the point is just drug-drug interactions, and I think we'll begin to see this someday, even in CVS, is when genetic profiles become much more commonplace and are entered into these interaction programs. We'll have these so-called phenoconversions where it ends up being a drug-drug gene interaction. And the final question is, this is what was your follow-up plan for this patient? And really you just want to monitor response and monitor side effects. So quick teaching point is, how do we monitor response in OCD? For this, I'm going to bring you back to that paper by Fensky and colleagues that I talked about earlier, and we're going to go to the monitoring section. You can see higher than usual doses sometimes used, so careful monitoring for adverse effects such as serotonin syndrome, so that should be part of your monitoring plan. But what about the actual disease state itself? What you can see here, you can have standardized diagnostic tools, or you can use two commonly used patient self-report inventories for OCD. And they even link to them here. There's the so-called Obsessive Compulsive Inventory Revised, or the Florida Obsessive Compulsive Inventory. So that can probably be part of your actual monitoring plan. And additionally, the gold standard scale for OCD is the Yale-Brown Obsessive Compulsive Scale, and for short we call it the Y-box. So let's take a look at the Y-box. This is an example of the Y-box 2, because sometimes they update these a little bit. Essentially, it's a clinician-administered scale. It's quite long. You have to actually be trained to give it. But what you can see here, if we get to the actual scale part, is that it goes over obsession, so current or past, and it makes a check mark here. So it's that the clinician would ask, it'd probably be more of a conversation. They would say, what type of obsessions have you had? And if they said they had an excessive concern with germs or fear of eating certain foods, they'd get certain check marks here. And they would do the same thing with compulsions. So they'd ask, what kind of compulsions do you have? A lot of people who have excessive obsession with germs have an excessive or ritualized hygiene strategy to deal with those obsessions, or they might have a checking compulsion, things like that. Then what types of avoidance behaviors do they have? Avoiding doing things, avoiding contact with contaminated objects, etc., and so forth. And then they kind of collate those items, and then they actually assess for severity, asking time occupied by obsessive thoughts, obsession-free intervals, etc., and so forth. And so basically what happens in the end of the Y-box, again, this is a long clinician-administered scale, but they can actually rate them. This would be the quick scale version here, from 0 to 5 in each of these categories, and then they add them up at the end, and it would tell you how severe their OCD is. And so this could be a method, especially if you're working in a psychiatric clinic, to monitor the efficacy of the drug. Then we have a case follow-up. After 6 weeks of therapy on citalopram, the patient describes significant but not total relief of symptoms. Her obsessions occur at half the rate that they were previously were, and she is able to function better at work. She is less distressed by her thoughts and feels that she is in better control. So, what is your plan at this follow-up? So the plan really should be to continue dose at 40 milligrams. If you had to assume this patient was on omeprazole, I think you would still continue the dose at 40 milligrams and monitor very closely for side effects. For the patient that's not on omeprazole, you might consider a dose increase in future if the full control is not achieved. And then for that patient on omeprazole, you might consider a dose increase, but maybe a little bit less to 60 instead of 80 or something like that. And you'd want to continue those periodic follow-ups for side effects, especially that QT prolongation, although that's very rare and the data on it's somewhat questionable. You still want to make sure you're monitoring for those side effects. So that really completes our case here. I think that's a relatively lengthy walkthrough of applying pharmacogenetics to a psychiatric case. And I think you could do this over and over again and do it very quickly from now on, because there's actually some good CPIC-based guidelines out there for several psychiatric pharmacy classes, with future ones in the pipeline that I know of, especially antipsychotics. They're working on one. And so this really gives you an idea of doing the whole kind of pharmacist process to go through the data to make the assessment that includes pharmacogenetic information, and then make that plan and follow up for that patient based on that pharmacogenetic information. Thank you.